Hello there and welcome to Myeloma Australia. My name's Steve Roach and today is the first of our National Myeloma Month events for 2021. The first thing we'd like to do is make an acknowledgement of country to our Indigenous people. We acknowledge the traditional owners of the land on which we are meeting and which we are watching this seminar. We pay our respects to their elders, past and present, and the Aboriginal elders of other communities who may be here today. And isn't it fantastic to be into another National Myeloma Month? After the last year and all the trials and tribulations we've been through, we did learn a lot, and we had an enormous amount of people throughout the country watch all our seminars last year. So we're doing a bit of a hybrid this year where we're having 3 online seminars and a series of face-to-face meetings, cup of tea, catch-ups with guest speakers around the country. And we're so excited to be seeing everybody around the country all over again. Our themes this year for National Myeloma Month are awareness, empowerment, resilience, and hope. And they're great themes at any time, but particularly for the myeloma community. Today, all our talks are based around empowerment and resilience. And we've got a fantastic lineup for you all, and I hope you enjoy this, whether you've watching it live right now or whether you're watching it on the recording. So we have live seminars on today, obviously, on the 1st, on the 15th, and on the 29th of the month, and then another series of live events which you'll hear about via your local myeloma nurse and National Myeloma Australia nurse. We've also got a fantastic program going on this year called 38Mate. And 38Mate is an awareness program to try and let the rest of the country know about myeloma. 38 Australians are diagnosed every week with myeloma. And so we're trying to let people know about that. We don't want the first time you hear about myeloma being the time that you're diagnosed or someone you love is diagnosed. So we've got our 38Mate caps, and we've got a video series, which I hope doesn't drive you too mad on your social media from this point on, but we'd love you to share our major 38Mate video and all the videos of our ambassadors who are telling their myeloma story, and do that right through National Myeloma Month. You didn't come to hear me, you come to hear our fantastic speakers today. So thank you for being here, and I hope you enjoy it. And with that, I'm going to throw over to EJ Furphy, who is there anchoring today. So EJ, over to you. Thank you.
Thank you, Steve, and welcome everybody to our first seminar for National Myeloma Month 2021. The theme for the seminar is Empowerment and Resilience. We'll be joined today by 7 wonderful speakers. If you have any questions for our speakers, please send through your questions using the question form, which is underneath this live stream. Our team are looking forward to receiving your questions. If due to time constraints, we are unable to get to your questions, we'll endeavour to respond to your questions next week via our email. Like all our seminars, we value your feedback. Please remember to fill in the evaluation form at the completion of the seminar. The evaluation form can be found underneath this live stream. This seminar will be available to watch again at a later date via our website from later today. You are able to access it by heading to our website and clicking on the seminar link. I'd like to welcome our very first speaker, the wonderful Dr. Haseeb Siddiqui, Consultant Haematologist at Fiona Stanley Hospital in Perth. He completed his general physician and haematology training at Royal Perth and Sir Charles Gairdner Hospital before undertaking a 2-year fellowship at the Mayo Clinic, Rochester, in myeloma, amyloidosis, and transplantation. His clinical interests are optimising treatment outcomes for patients with myeloma and amyloidosis and immunotherapy. He is the plasma cell lead and part of the CAR-T group at Fiona Stanley. He is a member of the ALLG Myeloma Working Party, the Australasian Amyloidosis Network, and AirMark Research Advisory Group. Thank you for waking up super early and presenting to us this morning.
Thank you so much, EJ. I just want to thank you and Myeloma Australia for inviting me to speak at this event. It's truly a privilege to be here, and this is the part of my job that I enjoy the most. So today we'll be talking a little bit about multiple myeloma and focusing on treatment for multiple myeloma. I hope that the information I share with you in this talk is helpful and useful to everyone who's tuned in. So just to give you a little bit of an overview of the talk, we will start off by just talking about some basics with regards to myeloma and how we diagnose it. And then I'm going to take a little bit of a historical look at myeloma over the years, focusing on how the treatments have kind of evolved over time. And then we'll discuss the current standard practice and treatment in Australia, and just a little bit on some of the more exciting treatments that are on their way. And hopefully there'll be 5 to 10 minutes for questions towards the end. So what is multiple myeloma? Well, myeloma is a cancer of plasma cells. Plasma cells are a type of white blood cell that basically reside in the bone marrow, and they help us fight infections. They produce antibody proteins that are an important part of our immune system. And there are about 2,000 cases of myeloma diagnosed a year, and it accounts for about 1.5% of cancers in total. So it's definitely not as common as some of the more common solid organ malignancies like breast cancer or colorectal cancer, but it's a significant proportion of the blood and bone marrow cancers that we deal with. The hallmarks of myeloma are these things called crab features. So myeloma cells reside in the bone marrow, as you can see in this image. Normal plasma cells produce these antibody proteins that help us fight infections, but in myeloma, these plasma cells become cancerous and they start to grow in the bone marrow. And as they do, they can cause a number of things. One of the things that can happen is that they start eating away at the bone and cause these lytic lesions or bone lesions. And as they do that, they release the calcium from the bone into the blood, and the calcium level can go up. The antibody proteins that they secrete, particularly the light chains, which we will discuss a little bit later, can cause problems with the kidneys. And as they grow in the bone marrow, they prevent the bone marrow from doing the normal things like producing red blood cells. And so people can become anemic. And so these are the symptoms that myeloma patients will often present with and are an important part of making the diagnosis of multiple myeloma. Myeloma often is preceded by these precursor conditions, which you may have heard of, namely monoclonal gammopathy of undetermined significance, or MGUS, and smoldering multiple myeloma. In these precursor conditions, we have some of these malignant plasma cells in the bone marrow, but often that they haven't expanded in the bone marrow enough to cause problems. So we will find that there's a protein in the blood, but typically we don't find those symptoms that I discussed. So the high calcium, the kidney problems, the anemia, or the bone disease. And thus far, standard of care is that if you have one of these precursor conditions, monoclonal gammopathy or smoldering multiple myeloma, you do not need treatment. And really the standard of care is to monitor to see if there is any signs that this is progressing and becoming more aggressive to the point of you needing treatment. So the antibody proteins that these plasma cells produce are important because they're a very important part of how we monitor multiple myeloma. So these antibody proteins are shaped in the shape of a Y, as you can see on the image there, and they are formed from heavy chains and light chains. And the heavy chains are the immunoglobulin proteins we talk about, and there are 5 different types that are typically tested for, so IgG and A and M and D and E. The more common ones are IgG and IgA, And then the smaller components of this antibody protein are the light chains. And there are two types of light chains that we monitor for, kappa and lambda. And this protein testing allows us to monitor progress in multiple myeloma using a simple blood test. So it gives us a very good surrogate for what's actually happening in the bone marrow where the problem is originating with the plasma cells. So how do we diagnose myeloma? Well, broadly speaking, it comes down to three things: blood tests, imaging, and a bone marrow biopsy. The blood tests are to look for the things that we mentioned: anemia, high calcium, problems with the kidneys, and they're very important in helping us stage myeloma. The imaging usually involves a CT scan of the bones from the head all the way down to the toes, and specifically we are looking for these lytic lesions, these little areas where the myeloma cells are eating away at the bone. And as you can see on this CT scan of the vertebra on the right, there are these small little holes that the myeloma has created in the vertebra, and this can progress to the point of weakening the bones to the point where they can even fracture. The bone marrow biopsy is absolutely critical for the diagnosis of myeloma. And on the image on the right, these are the cells that we look for. The arrow is pointing to one of these plasma cells. And when we do a bone marrow biopsy, we look at it under the microscope and we try and identify these plasma cells in the bone marrow. And this is how we prove that the problems all originate from these cancerous plasma cells in the bone marrow. And we diagnose myeloma based on the bone marrow biopsy. So how do we stage myeloma? Now, this is a question I often get asked, and often people come in with preconceived ideas from other cancers where staging really refers to, well, how much of my body is this affecting? Has the cancer spread from one location to the other? And myeloma is a little bit different to that. We don't think of staging as, is this a local problem that has spread to other organs? But rather, staging really gives us an indication of how the myeloma is likely to behave, whether it's going to be more aggressive or maybe less aggressive. And the important tests in staging are blood tests. And we look at a few different things on the bloods. We look at the albumin, which is a good protein that the liver produces. We look at the beta-2 macroglobulin, which is a bad protein that the cancerous myeloma cells produce. And we look at the LDH, which gives us an idea of how proliferative the myeloma is. The second important part of staging is cytogenetic testing. And this is when we actually look at the chromosomes in the myeloma cells. And what we know is that there are certain changes in these chromosomes that occur in the myeloma cells that may tell us that the myeloma behaves a bit more aggressively or less aggressively. Based on these features, so the blood tests and the cytogenetics, we can stage myeloma using the international staging system as stage 1, 2, or 3. And again, this doesn't tell us necessarily whether the myeloma has spread to lots of locations in the body, but rather gives us an indication of how it's likely to behave. Thus far, although there's a lot of research looking into whether there are ways we can optimize treatment for myeloma that is at a higher stage or likely to behave a bit more aggressively, a standard of care for anyone who's newly diagnosed is the same, whether you're stage 1 or stage 3. So what are the goals of treatment? Well, we know that myeloma is incurable. So we haven't yet found that one treatment that we can give people and say, look, we think the myeloma is gone forever. It's never going to cause a problem again. But it is very treatable, and we'll discuss treatment in more detail. The goal is to try and kill off as many of these cancerous plasma cells from the bone marrow as possible. And we're aiming to achieve a remission to try and help patients live longer, improve their quality of life, and really prevent any complications that can occur. And those complications, the goal is to prevent complications from the myeloma, but also complications that may arise from the treatment for the myeloma. So I thought we'd sort of go back and have a look at the history of myeloma to help us understand how we've gotten to the point where we have our current standard of care treatments. This is an image of a depiction of one of the earliest cases of myeloma, a lady by the name of Sarah Newbury. And this was a case that was described in 1844. And this was a lady that unfortunately had this terrible deforming bone disease with very brittle bones that fractured very easily, and is really the first known case of what would later go on to be known as multiple myeloma. She was diagnosed by Dr. Solly, and what she got treated with was orange peel and rhubarb, something that you're likely to find on a brunch menu as opposed to treatment for myeloma nowadays. The second more famous of the cases that were diagnosed was a chap by the name of Thomas McBean. And again, it was in the mid-1800s. He was a young man who suddenly presented with excruciating pain in his sternum and his bones. And people who have experienced lytic bone disease from myeloma or fractures from myeloma may get a sense of what this man went through. He was initially treated with bloodletting, and he had some improvement. And it's odd to think that bloodletting would improve symptoms in someone with myeloma, particularly if they're anemic. But nevertheless, he went on to one of the first forms of maintenance therapy in multiple myeloma, which involved bloodletting with leeches. Again, a far cry from the kind of maintenance therapy we use nowadays. So if we kind of look at the timeline, those first cases were described in the mid-1800s, and really over the course of the next 100 years, very little changed in terms of treatment for multiple myeloma. There wasn't a good understanding of how to treat this disease. Towards the latter part of the 1800s, the term multiple myeloma was coined, which just means multiple cancers of the white cells. And towards the late 1800s, we finally figured out that the problem was these plasma cells in the bone marrow. And it wasn't until the sort of 1930s that we really had a better understanding of how people with myeloma present. The anemia, the problems with the kidneys, these bone lesions were described in a report by colleagues from Johns Hopkins in 1928. And I guess one of the important breakthroughs in multiple myeloma came in 1939, when we identified this protein spike and the ability to detect a protein in the blood that shouldn't be there. And that was an important part of being able to diagnose myeloma and subsequently monitor it. However, in that 100 years, really nothing changed in terms of treatment. This is an excerpt from a medical textbook in 1948. And when discussing prognosis and treatment of myeloma, and I'll read a little bit of this excerpt to you, the disease is uniformly fatal with an average duration of life of 2 to 3 years. Occasionally, there are remissions and exacerbations. They recommend radiation therapy for symptoms and blood transfusions. Otherwise, the treatment is symptomatic. So no real progress in terms of treatment. And another interesting little historical piece is that in 1947, there was a trial of urethane, or what is now known as polyurethane, which we know is actually a carcinogen. And the trial involved comparing urethane to a cherry cola flavored drink, or otherwise known as Coke. Again, a far cry from the kinds of clinical trials that we run now. But really, if we're talking about breakthroughs in terms of treatment for multiple myeloma, the first real breakthrough was identification of a drug called melphalan, which is a traditional style of chemotherapy that works by damaging DNA and killing off these cancerous cells. And we have the old USSR to thank for that. The first reports of this being useful in myeloma came from the USSR, and subsequently by a Dr. Bergsagel, who was originally from Canada. And the Bergsagels have kept it in the family. His son is now a very famous and avid myeloma researcher who works at the Mayo Clinic. And shortly after that, we figured out that corticosteroids work. And I'm sure many of you are familiar with corticosteroids, whether it's dexamethasone or prednisolone. But between the 1960s and the 1980s, we figured out that this is an important treatment for multiple myeloma. And in that time period, between the 1960s and 80s, really what became standard treatment for multiple myeloma was combining melphalan with this corticosteroid prednisolone. And it wasn't until the mid-1980s that we had the next big breakthrough, which was an autologous stem cell transplant for myeloma. The first reports of this was from the University College in London, where they used a stem cell transplant for a patient with plasma cell leukemia, and subsequently for 8 patients with multiple myeloma, using a very high dose, a very high intravenous dose of this drug melphalan. And really that heralded a paradigm shift in the treatment of multiple myeloma. And very quickly, a stem cell transplant became standard treatment for multiple myeloma. So what does a stem cell transplant involve? Well, I like to break it up into 2 parts. There's the stem cell mobilization, which is collecting your stem cells. We harvest them by giving you a medication called G-CSF to stimulate the bone marrow to release the stem cells into the blood. Once there are enough floating around, we hook the patient up to an apheresis machine where the blood goes through the machine, and we collect the stem cells, and the rest of the blood is reinfused. And then we cryopreserve the stem cells in the fridge, essentially. And that's the first part, and that's very separate to the actual transplant, which then involves us giving you a very high dose of chemotherapy, the drug melphalan, and then subsequently followed by reinfusion of those stem cells that we've collected. This melphalan is designed to kill rapidly dividing cells, and so we hope that the chemotherapy gets rid of the myeloma cells, but in the process, we know that it gets rid of all the bone marrow cells. So if we didn't have those stem cells, the bone marrow would be wiped out and would not regenerate. And these stem cells that we reinfuse usually take about 2 weeks to help regenerate the bone marrow and help produce normal red cells, white cells, and platelets. Why do we do it? Well, like I said, after its initial application in the 1980s, over the next 10 or so years, there were a number of clinical trials that showed that if you used a stem cell transplant, it was very effective for myeloma and it improved survival. And so it became the standard of care therapy for myeloma patients from about the mid to late 1990s onwards. Should everyone get a transplant? And the short answer is no, because it's not a walk in the park. There is significant toxicity associated with an aggressive treatment like a stem cell transplant. The actual transplant process is a 2 to 3 week process, and your white cell count goes to 0 for about 10 to 14 days. And of course, during that period, you're at risk of infections. The melphalan drug particularly can cause toxicity, and gastrointestinal toxicity is the main side effect. So nausea, diarrhea, those kinds of symptoms are common. And the risk of a life-threatening complication with this procedure is about 1%, but that increases as we get a bit older and as the organs get a little bit frailer. And so if the kidneys aren't working as well or the heart's not working as well, then that risk increases. And so we have to be aware of that. And if we think that the risks outweigh the benefits, then we do not recommend a stem cell transplant. There is a rough age cutoff of about 70 years, and that varies depending on where you go. There are certain European countries where that cutoff is 65 years of age. In the United States, there are certain places that sort of push it out to 75 years of age. But it really comes down to assessing the risks and the benefits and making sure that the benefits of the procedure outweigh the risks. So the next real sort of big discovery in multiple myeloma came with the introduction of thalidomide and immunomodulatory drugs. And really, this heralded a new era of treatments for myeloma, or the era of novel agents or newer therapies for myeloma. Thalidomide, you may have heard, was a drug that was introduced in the late 50s as a sedative and a treatment and monitoring of morning sickness by this German company, Grünenthal. And it very rapidly gained popularity in many countries, but wasn't FDA approved in the United States. And it had a disastrous side effect when used in pregnant women for morning sickness, which many of you may have heard of, these fetal congenital abnormalities. And interestingly, it was an Australian doctor who sort of showed this connection, Dr. William McBride from New South Wales. But the story of thalidomide in myeloma is a really interesting one, and one that really highlights the importance of patient advocacy. So, you know, the story goes back to a 35-year-old cardiologist who was diagnosed with myeloma in New York. He'd been seen by the doctors at Mayo Clinic, had his usual treatments, chemotherapy, stem cell transplant, but after 7 or 8 years was approaching the end of the road. And he was seeing Dr. Barlogi at the University of Arkansas in 1997. His wife had heard about this anti-angiogenesis drug being developed at Harvard, and this drug was thalidomide. You know, after the disastrous early years of thalidomide, people realized that it was an important drug in preventing blood vessels from growing. And she really pushed Dr. Barlogi to consider this drug for her husband. There had been some research and some clinical trials into its effects in cancers by the National Cancer Institute. And eventually Dr. Barlogi agreed and tried thalidomide in this patient. And unfortunately for him, it actually didn't work. But at the same time, Dr. Barlogi tried this drug for one of his other patients who had a remarkable response to thalidomide, which, you know, was really an absolutely new discovery in terms of myeloma treatment. And this is what prompted one of the landmark clinical trials, and that was thalidomide for people with relapsed myeloma. And they found that it worked in 1/3 of patients who had already had, you know, other treatments like chemotherapy and stem cell transplant. And really, that heralded the novel era, or the era of novel agents for multiple myeloma. So you can see on this timeline, thalidomide was discovered in the late 1990s, in 1999, and the next couple of decades is just littered with new discoveries and new agents for the treatment of multiple myeloma. So subsequent to that, we have now discovered second-generation immunomodulatory drugs, lenalidomide, pomalidomide, which you may have heard of, bortezomib and proteasome inhibitors, and subsequent to that, carfilzomib, which is a second-generation proteasome inhibitors, all shown to be extremely effective in treating multiple myeloma. And more recently, new forms of immunotherapy or monoclonal antibodies, daratumumab, which is now approved for the treatment of relapsed myeloma in Australia, but there are other medications in that same category. And of course, the future, chimeric antigen receptor T cells, or CAR T cells, bispecific antibodies, and new novel drugs, all undergoing clinical research at the moment and being shown to be promising in treating multiple myeloma. So how do we currently manage newly diagnosed myeloma? Well, we like to split it up into people we consider a transplant for and those we think the risks are too high and that we shouldn't be giving a transplant. In people who we think should get a transplant, we usually use combinations of chemotherapy drugs to try and rapidly control the myeloma. And the most common combination is 3 medications, bortezomib, lenalidomide, and dexamethasone. People will receive that often for 3 or 4 cycles before we collect the stem cells and perform the stem cell transplant. And what is standard of care now really is to use maintenance therapy with lenalidomide after the transplant. For people that we think the transplant is is too high risk and that we shouldn't do a transplant, well, we do have a lot of different options. We can use combinations of 3 drugs, like the bortezomib, lenalidomide, and dexamethasone, or we can use combinations of 2 drugs, bortezomib in combination with dexamethasone, or the lenalidomide or Revlimid in combination with the dexamethasone. And each of those have their own unique side effects. Some of it is driven by patient preference. For example, the lenalidomide is a tablet, which you can take at home. The bortezomib is an injection under the skin that you have to present to hospital once a week to have administered. And usually we use those treatments and we continue them until the treatment stops working. Or if, of course, you're not tolerating it, then we consider either reducing the doses or adjusting the regimen. Supportive care is a very important part of myeloma therapy. So there are some common things that we do. So to help prevent infections, you might be started on things like antibiotics or antiviral drugs or antifungal drugs. Bone protection is a very important part of myeloma treatment. As I mentioned earlier, the myeloma likes to weaken the bones and cause these lytic lesions in the bones. And bisphosphonates, usually Zometa, is given as a monthly intravenous infusion to help protect the bones, help prevent fractures, help prevent new lesions. Along with that, calcium and vitamin D are very important to keep bone strength. To help prevent clotting, so some of the medications that we use for myeloma, such as the Revlimid or lenalidomide, can increase the risk of people developing blood clots. And so often we put patients on an aspirin once a day or occasionally something a little bit stronger to help prevent risk of clots. Physical therapy and exercise I always recommend is very important. And something that I think is absolutely vital is being involved in support groups. Countless numbers of my patients have described how important that support group is, meeting other people who are going through a similar treatments or a similar phase in their diagnosis is invaluable in keeping your mental health. So I really encourage you to be part of these support groups. I know Myeloma Australia runs these support group meetings all around the country, and I'm a big advocate for being involved in these support groups. So how do you know the treatment's working? Well, luckily we have this protein and light chains that we can monitor in the blood, and it saves you from having to do repeat bone marrow biopsies. Although we do repeat bone marrow biopsies at certain time points, most of the time we can tell how things are going and how the treatment is working by monitoring the protein in the blood and the light chains. And so we have these different categories of response. A partial response if the protein is reduced by 50%, a very good partial response if it goes down by 90%, and if it returns to normal, well, we say you've had a complete response. And so that's a way of assessing response or remission in multiple myeloma. And we're constantly figuring out new ways of assessing that. And so there is this concept of minimal residual disease, which we usually do on bone marrow samples that can look at the very deeper levels within the bone marrow to see if there are any of these cancerous myeloma cells left behind. And those are the ones that are usually the reason why the myeloma comes back in the future. So treatment for relapsed myeloma, once it comes back, I always recommend you discuss clinical trial options with your physician. Outside of the clinical trial, a lot of what we do in terms of treating myeloma that has come back is guided by what we have access to on the PBS. And so there are a number of drugs that I've listed there that we have access to and that we usually sequence through to try and manage the myeloma and try and put it back into remission. But that's something for each individual to really discuss with their own physician. Just to give you an idea of the utility of clinical trials, currently at our hospital, we have clinical trials that include the following different medications, all shown to be very effective in multiple myeloma, and none of these therapies are available through the PBS currently in Australia. And so again, I really do advocate for clinical trials in this setting. Side effects. So an important thing to discuss in managing myeloma is that whilst we want you to live longer, we want you to live good lives and have a good quality of life. And so managing side effects is very important. The common things that you may experience with this drug bortezomib, it can upset the gut balance a little bit and cause constipation. There is a risk of shingles being reactivated, and so we usually start people on an antiviral called valacyclovir, and it can cause neuropathy, numbness and tingling in the hands and feet, and so that's an important thing to look out for. The lenalidomide tablets are generally well tolerated. We have already discussed the risk of thrombosis or clots, and so often people are on an aspirin. It can cause a rash, which is generally manageable with creams and antihistamines, but patients sometimes report fatigue and diarrhea. Again, generally manageable, but sometimes we do have to adjust the dose. The medication that I think people complain about the most and describe the side effects the most is the steroids by far. And we understand that the steroids are probably the most difficult part of myeloma treatment to tolerate. And I've listed a whole heap of side effects that can occur. I'm sure anyone who's been on steroids understands this. What I will say about steroid therapy is that it's a very important part of myeloma treatment, but over the years, we're understanding how best to use it. So, we now give it usually once a week. There was a time we were doing that 4 times a week, and we've realized that that dose was just too high and too toxic. And so there are more clinical trials that are looking at, well, how quickly can we reduce the dose of steroids? What's a safe way of doing it? How can we minimize the side effects of this drug as much as possible? And so I think there will continue to be changes in how we use steroids for myeloma therapy in the future. What is the future for myeloma therapy? Well, I think the most exciting thing to come out in the last 5 years is immunotherapy using CAR T cells, which has gained traction in many different blood cancers, but also in myeloma. What does CAR T cell involve? Well, this diagram depicts what what chimeric antigen receptor T cells involve. We take your own lymphocytes or T cells, which are one of the immune cells in your body that help you fight infections and even cancers. We send them off to the lab where they are genetically modified to be able to target your cancer. We grow them in the lab to expand, and then we infuse them like we infuse stem cells. And once they're reinfused in the body, the hope is that they find the cancer and target the cancer and help kill off those myeloma cells. And the first CAR T cell product for multiple myeloma was FDA approved in the United States in 2021. And I really see this as a big part of myeloma therapy in the next decade. So just to summarize, myeloma is a cancer of plasma cells. It originates in the bone marrow, causing anemia, high calcium, problems with your bones and kidneys. The treatment is really aimed at killing off these cancerous plasma cells, and we use combinations of drugs as standard treatment for multiple myeloma. A stem cell transplant is an important part of myeloma treatment for those we think can tolerate it. I think the important thing is that there has been much progress in the last 2 decades, and I suspect there will continue to be a similar, if not exponential progress in myeloma treatment over the next 2 decades. And hopefully we can get to that point where we achieve cure for multiple myeloma. Thank you for listening, and I'm happy to take any questions.
Thank you so much, Haseeb. That was absolutely fantastic. We've got one question for you, if that's okay.
Yep.
It's from a patient in New South Wales, and he asks, how common is lymphedema in patients with myeloma? Could this be a side effect from lenolidomide, or could there be another reason I'm experiencing this?
So I think, the causes for lymphedema are common or varied, should I say, and really there isn't specific lymphedema from the multiple myeloma is not something we necessarily see, but there are medications that can cause swelling in the legs. So dexamethasone is the most common that does that. There are some problems that myeloma can cause with the kidneys where you lose a lot of protein and you can get fluid overload from that. And so you can get swelling in the legs. Occasionally, if you have, myeloma spots that are pushing on some of the blood vessels or some of the lymph glands, that can sometimes cause a bit of swelling as well. But, so it's hard to say how common it is, but I would say that, a lot of people that are on steroids will experience some degree of it, but there can always be other causes that, it'd be important to discuss with your doctor.
Okay, thank you. Thank you so much for such a wonderful presentation, Haseeb. Your slides were amazing. You're fantastic. We love you here at Myeloma Australia. And I particularly love the immunoglobulin slide.
Not a problem. It's been my absolute pleasure. Thank you so much for having me.
Great, thank you. Now, I'd just like to remind everybody about our new campaign, the 38 Mate. Hop onto our website, have a look. We've got some caps to purchase, and there's some great stories and slides there for you also to view. I'd now like to introduce the newest member of our team, Emma Hubens. Emma has joined the team at Victoria as one of our myeloma support nurses. So welcome, Emma. Thank you.
Okay, here we go. 3.
Thank you so much, EJ. I'm very excited and honoured to have joined the Myeloma Australia team and to be part of our first online event for Myeloma Month. I would like to now introduce our next two speakers, Myeloma Australia's President Brian Rosengarten and CEO Steve Roach, who will be presenting on Myeloma Australia advocacy. Together, Brian and Bob Moran founded Myeloma Australia after their wives were diagnosed with myeloma. Brian was our vice president from 1998 and became president in 2008. Brian is also chairman and chief executive of Rosen Distributors and a former pharmacist. Steve has a background in management and marketing in business, sport, and the non-for-profit sector. He has been general manager and CEO of organizations in education, business services, equipment vehicle rental, transport, and the marketing industries. Steve is also an ex-sportman, having played VFL, AFL for Richmond, Collingwood, and St Kilda, and has also played and coached in the VFL at country and suburban levels. Welcome, Brian and Steve, and thank you for being with us here this morning.
Thank you, Emma. And that was a fantastic introduction. I feel like I wrote that myself, so thank you very much. Look, it's a pleasure being here, and we're just going to give a short overview of the advocacy that we do here at Myeloma Australia, and that we might have done in the past as well, and why we've arrived at this point. So advocacy really means about speaking up for our community, at least from the Myeloma Australia sense anyway. And if that means speaking up in particular to get treatments available to myeloma patients, then that's what we're here to do. But there are many parts to this, so we're just going to briefly talk through those. But I think it's really important that we understand where we come from and why we're doing this. So there's no one better to tell that story than one of our founders and our president, Brian Rosengarten.
Thanks, Steve. Yeah, my story started in about 1996. My wife Rosalind was diagnosed with myeloma just after turning 50. She had been visiting doctors for about 15 months because she'd been suffering with severe rib pains and no one could find out what the problem was. We had no idea what myeloma was when she was told. After searching the web, we found lots of information, but most of it very frightening and not very professionally written. We went looking for a support group and we were told that there was none in Melbourne. We discovered a group on the web spreading all the articles they could find. Most of them were not very accurate. At this point, I went to the Cancer Council of Victoria looking for support groups, and I was introduced to another family, Bob and Glenys Moran. And they were doing the same as what I was doing. And we were brought together and had a meeting at the Cancer Council with their head of their support groups, a lady called Pat Dobson, who helped us to start what we called Myeloma Victoria in those days. And that was about 1998. Our group consisted of Bob and Glenys, Bob's wife, and Glenys was the myeloma patient, Pat Dobson from the Cancer Council, a social worker, and doctors Miles Prince and Paul Mitchell. We aimed to provide information to other myeloma families like our own. We were concerned about the lack of good information, and so we took on the task of providing this once we had it first checked for accuracy by Professor Prince. We published a quarterly newsletter and information sheets and ran workshops and seminars to spread this information. And I was amazed that we could always get some of the Victorian hematologists to present at a Saturday morning workshop, and never ever do they charge for their time or effort. And they're only too glad to be able to help us. We also employed a support nurse. We knew that this is the way to go to get professional information. And we used this to help educate and inform the community. We found there was a need in the medical and nursing professions for myeloma information, as most GPs rarely ever saw any myeloma patients. When Ros was diagnosed, there was no specific anti-myeloma drugs available in Australia. The medical profession was using a range of chemotherapy drugs which all had very harsh side effects. The first breakthrough was when thalidomide was first used in America to treat myeloma in 1997 and was finally approved in Australia in 2006 for relapse myeloma and finally released in 2009 for first-line treatment. The discovery of using thalidomide was quite an interesting story. There was a patient who did their own research to find something that nothing they tried was working at those days. And they found that they thought the thalidomide might do something to help. They convinced their doctor at the time to prescribe it for them. And for surprising enough, it actually had some success with it. Further trials were then run to prove these results. And that's how thalidomide came on the market. We worked with Pharmion, the pharmaceutical company at the time that originally distributed thalidomide in Australia. We were asked to help review some of their presentations and papers, and also to help to explain the extensive restrictions put on patients who were being prescribed with thalidomide. They had to sign these multi-papers and they had to sort of basically state, they were using 2 forms of contraceptive just to prevent any risk of any pregnancies. We also ran training sessions with their management and sales force, explaining how myeloma affected the patients. Ros was a part of our team at one of these sessions, and she was able to tell them about how myeloma and the treatments had affected her. I remember when Professor Prince used to explain at our workshops how thalidomide worked, as very little was known. He told us that they only knew that it slowed the blood supply to the abnormal plasma cells, which then reduced the nutrients that they needed to grow. Now, about 15 years later, the scientists have discovered how it works and this has enabled them to develop newer and better products. A group of us, which included Bob Moran, our co-founder, our CEO at the time, Professor Doug Joshua from Sydney, and myself went to Canberra to meet with the health minister and his subcommittee trying to get access to thalidomide. After waiting all day to meet with them, we got to speak to the subcommittee for about 10 minutes before the bell went, and they excused themselves. Each one of us had a short presentation, but only Professor Joshua had the opportunity to speak. In the early days, both Bob and myself had given a number of radio interviews giving information on both thalidomide and myeloma and answering questions and whenever ever discussed. a lot has happened in the 25 years since Ros was diagnosed, and I like to report that she's still very well and healthy even after all this time. Thank you.
Thank you, Brian. Brian's we talk about today being about empowerment and resilience, and I think Brian and his family and what they've done for Myeloma Australia really shows that, and talks a lot about advocacy. That there was a drug found, and we know the bad reputation of thalidomide, and we know that nobody really wanted to touch it, and in the past it was. It caused a lot of problems, but then there was a positive use for it, and Brian and the people involved with Myeloma Australia at the time, or the Myeloma Foundation of Australia at the time, managed to convince the authorities to put it on to the PBAC and the PBS, and that was the start of novel treatments for myeloma. Now, over the years, thalidomide, then Velcade, lenolidomide, carfilzomib, pomalidomide, now daratumumab. Now, something we thought would never happen is multiple therapies in Australia. We heard about them overseas, but they were so expensive, they were never going to happen in Australia. And now there's 3 multiple therapies available in Australia through the PBS. And we know it's not a perfect system, but Myeloma Australia keeps talking to the authorities to let your viewpoint be heard. So we've been involved in each and every one of those drugs being put onto the market, put into the market and put onto the PBS. We have asked you to contribute, and we'll continue to do that. There are 6 myeloma treatments coming up at the next PBS meeting. Some of them major, some of them minor, and we know that, and you'll be hearing about that from us over the next few weeks as we ask you to get involved and give your comments. And the treatments will keep evolving, and many new treatments will come on the market in the next few years. We have Dr. Nick Webber from Queensland talking about this in our and the latest treatments and where they're heading in the last seminar of the month on the 29th of May. So that'll be something to really look forward to. The other things that are happening, apart from the medicines, the CAR T cell therapies and the bites, and Myeloma Australia is involved in the development and getting of those things to Australia. Now, I know that Haseeb said before that the first CAR T cell therapies have been approved by the FDA in America, and we're still a way off in Australia, but we are talking to everybody that's involved about eventually getting those to Australia and making them a safe and worthwhile therapy for people living with myeloma. So we're very active with that. Our nurses are sitting on committees that are involved in those therapies, and myself and Brian as well. So there's much work going on behalf of the myeloma community in the background that is aimed at getting the treatments out there to make life better for myeloma patients and keep heading us towards the cure that we know will be there one day. The other thing we do in advocating for our community is obviously try and talk about awareness, and we're running our awareness campaign, our first ever really true awareness campaign. We're starting it this month. It'll be an ongoing campaign. You'll hear a lot about it this month, but it will be ongoing into the future. And we talk to our partners overseas, and we're involved with a couple of groups that involve between 30 and 40 myeloma patient organizations throughout the world, being up with the latest things that are going on, and what not just the treatments, but the latest information, that the latest support systems, the way everybody else is distributing their information. The Global Myeloma Action Network is an advocacy organisation that brings together around about 40 myeloma groups from around the world. And we're seen here in Australia as leaders in terms of how we're providing services to patients, which we're very proud of. And we've been involved with that group for 7 or 8 years now. We're involved with the International Myeloma Foundation and the International Myeloma Working Group. And so we're very proud of those associations, and to be able to talk on the international scene on behalf of Australian patients. And that really is what we're here for. As we go on today to talk more about empowerment and more about resilience, and through the month we talk about also awareness and hope, we want you to know that even if it's not at the forefront all the time, we're here talking about those things all the time on your behalf. We're talking about the next treatment that you need and how we can get better access for more people, for more treatments, and how we get more nurses out there to help more people, and how we promote and assist our community into the future till the day when we've got a cure. And we hope that's not a long way off, but until that day we're here and we'll continue to be doing that. Thank you for letting us do this and tell you a little bit about Myeloma Australia and what we're working to do for you. Brian, thank you so much for telling your story and Roz's story. It's such a story of hope.
Thank you.
And with that, we'll throw back to Emma and get back to the medical professionals and let you enjoy the rest of your day. Thank you.
Thanks very much.
Thank you, Steve and Brian. We are very lucky here at Myeloma Australia to have such a supportive leadership and one that advocates so strongly for better access and outcomes for our myeloma community. We are now going to play our very first 38-minute video and take a quick 5-minute break. So grab yourself a cuppa, have a stretch, and we'll see you back here shortly. Thank you.
Every week, 38 Australians are diagnosed with myeloma, an incurable blood cancer that develops in the bone marrow. There are currently around 20,000 Australians living with myeloma. Despite this, many people have never heard of myeloma until they or a loved one are diagnosed with it. This May, we hope to change that.
I don't want others to go through what my family and I went through, hearing about myeloma for the very first time when you're diagnosed.
When I was first diagnosed with myeloma, I had no idea what this disease was, and neither did any of my family or friends. In fact, most people thought I had a melanoma.
In the beginning, my carer's role was immediate, intense and prolonged for approximately 6 months, and then life went back to normal, albeit in the shadow of myeloma.
We were in complete shock and were confused as to what this unheard of cancer was. This was followed by denial, fear, researching, anger, and lots of scary feelings, finally accepting.
Being a mum of 2 young boys, 4 and 7 at the time, I was really overwhelmed and scared.
While Dad stayed positive and fought to the final hour through his 4-year journey with myeloma, his battle, pain and passing will be a scar that is felt forever by me, my family and all those lucky enough to have met him.
I've been relatively stable now for 5 years. I've been able to retire, live a pretty good life, travel, continue playing in a professional rock band, despite the side effects of treatment.
I have learnt, however, that through sheer strength, determination, amazing medicine and a very positive mindset, you can surprise yourself on how strong you really are when faced with adversity.
Myeloma is the second most common blood cancer. There are no confirmed causes and myeloma can impact adults of any age. Currently there is no cure, but with treatment it can be controlled for many years. Treatment options are constantly evolving, helping to improve and extend quality of life. Research into myeloma continues and there is hope that one day a cure will be found. We want people to know about myeloma before they or a loved one is diagnosed with it, and we need your help.
So how can you help? First, share this video. Share it far and wide. Share it on socials, on email, and even text the link. The more people that hear this message, the better. Learn more about me and the other 38 mates this May. We'll be sharing our stories on socials throughout the month.
Second, buy a 38-mate cap from Myeloma Australia's online shop. In fact, buy 2 caps for $38, one for you and one for a mate. Wear the cap and use it to start a conversation about myeloma.
Third, take a selfie of yourself wearing the cap. and upload it to your socials. Remember to tag Myeloma Australia and use the 38mate hashtag. If you're not on social media, you can email your photo to us.
Every action you take is supporting the myeloma community.
Thank you for throwing your weight behind 38 May.
Welcome back to our online seminar. I've got my 38 Mate cap and I can't wait to share this campaign far and wide. For our next segment of the seminar, I've got the pleasure of introducing some of our active members, Daniel and Christine. Daniel and Christine are in Brisbane, where they've been living since they moved to Australia from South Africa 12 years ago. They've always enjoyed camping, travelling, and Daniel's diagnosis of multiple myeloma in 2017 has not stopped them. When at home, they're involved in local community groups where they've formed close friendships with people with similar interests in home-cooked food, music, nature, and more recently, myeloma.
Thank you, Megan. Well, our journey began with a journey, and in this case, it was a walk called the European Peace Walk. On the map there, you should be able to see the blue line. It's a walk that goes from Hungary through Austria, Slovenia, Croatia, and ends in Italy. It's about 500 kilometers long. And in 2017, we decided that we would do this. So we spent the first half of the year getting fit, and we made it the first part of a 4-month trip backpacking around Europe and Asia. Christine took long leave from her work. I was doing volunteering work, so I was able to stop that. And we had a fabulous time walking around 25 to 35 kilometers a day. We had given up our rental before we left, put everything into storage, so we had no worries really. Towards the end of the trip, when we were in Asia, I started getting sort of sore back muscles, and I went for a couple of Thai massages, and that didn't really help. But we came back to Brisbane at the end of October, and I saw a physio who said, oh, it just seems to be a bit of inflammation about my ribs. And anyway, so Christine went back to work. I was supposed to be finding us a new place to live and sorting that out. But that first week, my dad, who was living in South Africa, he had to have a small op. And so I had to drop everything, and a week after arriving back, fly to South Africa and go and help him out. So I got there, my dad was okay, but my back muscles started getting worse. I saw a GP there, and he put me onto bed rest and Valium for a week. And that also didn't help too much. After a week of that, I ended up going to the hospital and saw a doctor who said, I'm not going anywhere. So they started doing some tests, did an MRI, and they found that a vertebra in the middle of my back was kind of collapsing and misshapen. A biopsy showed that there was some kind of tumor inside it, and that it was collapsing from the inside. In the meantime, Christine was asking, should she come out and be with me as well? And I said, no, don't worry. But her doctor sister in Canada said, yeah, I think you should go. So having just started her work again, she dropped everything and flew out to South Africa to be with me. So they didn't know what had caused this yet, this collapsed vertebra. So, but the most important thing was to stabilize my spine with screws and rods, because it was pressing on my spinal cord. And I didn't realize until I came out of surgery what was actually going to be done. And I had basically bolted my whole spine together with titanium scaffolding. Anyway, at that stage, I really didn't care what they did as long as they could relieve these cramps, because when I cramped, I couldn't breathe for sort of 15 or 20 seconds, and it seemed like a lifetime. But anyway, that helped a lot. And I asked the surgeon when I could climb mountains again. He said 6 months. But for the first 4 months, I had to wear a brace. I do a lot of exercise that the physio had given me. And initially, I could only stand up about 20 minutes a day. It was a huge benefit that I had started off fit, though. Christine arrived and she took care of everything, communicating with the travel insurance and friends and taking notes with the doctor. And it just made such a great difference having her. So in the meantime, the doctors were doing blood tests and began to suspect something called multiple myeloma. Now, I'd come from a family of engineers and IT people and property developers. We've got no idea. I didn't know anything about bone marrow biopsies or kappa light chains. Anyway, I really did realize, though, in hospital how good nurses are. And all the rest of the medical staff. They're really so wonderful. I wondered for a while if there was maybe a disadvantage of going public with telling people, friends and just the general people what the situation was, and would it have an impact on my insurance or something? But I decided that it wouldn't, and I posted it on Facebook, and people were so supportive. So that's really made a big difference. And all the way through, I've let people know what is happening. Because of my fragile back, we couldn't fly home. So we ended up spending what was meant to be a 3-week trip, became a 3-month trip. In January the next year, I had 4 weeks of radiotherapy, and again met more wonderful medical staff. We ended up having a fabulous holiday. We spent more time with my dad. I was able to increase walking every day. We discovered every cafe and restaurant in the area, and Christine's work was really super. They just said, do what you need to, take as long as you want. So after 3 months, at the end of January 2018, we flew home, and of course we were still homeless. But that was a really great advantage because we could choose a place to live which was near the hospital where I wanted to get treated. And we were able to simplify life. We got a small apartment, easy to keep, lovely surroundings, near the river for nice walks. And Christine was able to go back to work in reduced hours. So we were really unencumbered with other issues, and we could concentrate totally on that. I carried on doing walking, and in fact, every week for my chemo, we walked the 5 kilometers along to the river, and we did that for 4 months. Again, we met more wonderful medical people at the hospital where I was going, and Christine was able to attend all my appointments and took notes, which was very, very helpful because there's so much information going, and it takes a lot of concentration and trying to remember what the doctor said. So having somebody to sit with you and take notes is really a big benefit. During those 4 months, I learned to ride the effects of chemo and DEX. I had treatment on Friday. Movie nights was Saturday at 2 a.m. in the morning. By Monday, I was crashed, and I knew that was just a day where I'd stay in bed and sleep. And then starting recovery on Tuesday. But Tuesday night, I still wouldn't be feeling great, but we were in a community singing group, and going along there, I dragged myself along there. And by the end of the evening, I'd feel great with good breathing, meeting friends, and just take my mind off how tired I was feeling. I also continued to walk most days, which was really good with strengthening my back again, good for digestion, good for fatigue, and just general health and well-being. In August 2018, I had my stem cell transplant. Christine visited twice a day in the hospital, and she coerced me to do a couple of laps of the ward, which of course I didn't want to do, but again, that was good. It went really well. I was out in 13 days, but still I lost 4 kilograms of muscle. I was very grateful again that I had started off being fit. Soon after that, I did the Leukemia Foundation's Fit to Thrive exercise program, which was available at the time, a 12-week program under the guidance of exercise physiologists. that really helped to recover lost muscle. And I got the benefits of meeting people who were in a similar situation. I've remained good friends with them, and we get together regularly still. A few months later, we started attending the Myeloma Australia information sessions. And again, met more people there, same situation as us. And it's there's such good people, and it's been so informative as well. We always go along and learn something. There have been occasional hiccups, like when I've ended up in hospital with some sort of minor cold or something, but as soon as you hit 38 degrees, have to go and go to emergency. And having realized the benefits of exercise, in 2019, I was able to participate in a clinical study at University of Queensland looking at the effects of exercise on people with myeloma, and in particular, the benefits of resistance exercise and bone density. That was involved a 6-month exercise program with regular scans, x-rays, and fitness tests. Sorry. It was so good that after I finished that clinical trial, I continued with exercise physiologists and do weights training and walks as well. My walks have become runs now, and for the first time in my life this year, I managed to do a 10-kilometer run. So things are improving. We've been able to start traveling again. In 2019, we went, hired a camper van and went to Tasmania. And we enjoyed that so much, we bought a camper van ourselves. We've been to South Africa again. 2020, we had booked a trip, another 3-month trip in Europe. We were going to walk the Portuguese Camino and go cycling in France and go to a wedding in Greece. And of course, just after we had booked all that, everything was brought to a halt with COVID. But instead, we got in our camper van and we went to North Queensland for about 4 months. I was able to continue exercise while we've been traveling as well. The medical staff at the clinic I go to have been very accommodating. So I just say to them, look, I think we're going to be in Townsville at this date. Can you arrange that I get my port flushed or get Iridia infusion there? And they sort that out. And they say to me, we're keeping you going so that you can enjoy life. And so we're taking full advantage of that. Because of the good experiences we've had, when I speak to people newly diagnosed, I tell them, you know, it's bad, but you'll meet such good people and have great new experiences. Thank you very much. I think we'll hand over to Megan now.
Dan, that's absolutely fantastic and such a great opportunity to show people the full documentation of your journey. That's really rare to have such a really clear understanding of what you've been through. And it was evident through the whole thing, the importance Christine played in that journey. And I'm interested to hear from you, Christine, on what you've learned through this process.
Thanks, Megan. Well, I think the main learnings for me has been the excellent and reliable support that's available to us. We just need to tap into it. The other thing that I found is I've always been a strong believer in resilience and how important that is, and it's become even more important. So as far as support goes, in addition to our fantastic health services, there's the friends and family. They want to help, and we really need to make use of that. What we have learned during the process is that the family and friends are also in shock as much as we are at hearing of a diagnosis, and they feel helpless if they don't get involved. So, you know, aside from taking the pressure off yourself, you're actually helping them along the way as well. The other thing is learning about the fantastic resources that are available to us. You know, there's excellent and reliable resources. Now, for me personally, if I feel like I need to be empowered in this whole process, and learning about things empowers me, and then I feel in control of the situation. I also feel, well, it helps me to let go if I can't control the situation, because I understand it. I know there's nothing I can do about it. Now, examples of good resources is the Myeloma Australia booklet that's produced, that's on the website. I've read that many times. It's really great. And then also learning from other people's experiences, you know, whether it's the, you know, from the broader myeloma community. So whether it's, you know, following some discussion on Facebook or having a catch up with Myeloma Australia sort of meetups on Zoom or in person. And then of course these seminars, you know, we try and attend as many of them as possible. Now, on the topic of resilience, I've always felt, you know, mental strength and physical strength is very important to me. And I see it as this big bucket, you know, that's full of resilience. And every now and then there's a trauma, or, you know, you get emotionally tarnished by something and it gets depleted. And that's when we really need to top it up. And for me, that gets back to the family and friends and the support services, getting a lot of exercise and just having a lot of fun. And that's what I intend on continuing to do. Thank you.
Oh, Christine, thank you both. My name is Megan and I'm a support nurse in Brisbane, and know Daniel and Christine well, and they always bring a lightness and a positivity to our support groups. And I suppose that would be one of my final questions is anyone watching today hasn't been to a support group in person, what would you tell them that they might expect in one of our groups?
It's a very relaxed environment. I found people are quite open about things. I suppose it's a sort of unwritten rule that there's a little bit of a confidential little bubble space that you're moving in. Mm-hmm. But on the whole, it's very positive. And I think for people who've just been diagnosed, it's probably a good learning space and an opportunity to ask questions. Thanks.
No, thank you. I agree. We do. We get a mix of people at all different points, and certainly people when they're first diagnosed certainly have given me feedback that they learn so much for people that from like yourselves. So we're always grateful to anybody along their journey to join us. So I want to thank you both again for being so open and honest with your experience, and I'm 100% sure that our watchers today are going to be grateful for everything they've learned from you. So next, at the next start of our session, I'll be throwing to another one of our amazing support nurses, Emma, and we look forward to hearing about supportive care in myeloma. So thank you very much.
Thank you.
Thanks.
This opportunity to remind everyone to submit any questions you have via our website, and to please fill out our evaluation form after the seminar. Your feedback is very valuable to us and the ongoing improvement of our future online events and seminars. Our next speakers will be two of our myeloma support nurses, Rachel Mccann and Tash Clark, who will be presenting on supportive care measures. Rachel is a registered nurse who has over 8 years of experience working in various roles in haematology and oncology in Victoria and New South Wales. Rachel is currently completing her postgraduate studies in cancer nursing, majoring in haematology at the Australian College of Nursing. Rachel also currently works in the chemotherapy day unit at Southwest Healthcare in Warrnambool. She has worked as a myeloma support nurse with Myeloma Australia for over 2 years. Rachel has recently transferred from our Newcastle team in New South Wales and joined our team here in Victoria. Tash is a registered nurse with over 20 years experience in haematology and oncology, working both clinically and in nursing education. She joined the Myeloma Australia team as a myeloma support nurse for Queensland in 2018. Tash also currently works at the Princess Alexandra Hospital in the Oncology Day Unit and as a data manager for the Myeloma and Related Diseases Registry. Welcome, Rachel and Tash.
Morning. Thank you so much, Emma. Hello, everyone, and thank you for your time today. So as Emma said, I'm Rachel Mccann, and I'm one of the Victorian myeloma support nurses for Myeloma Australia. So it's such a privilege to present today with my colleague Natasha in Queensland. It's pretty amazing that we can co-present from different states, the wonders of technology. So we're going to be talking to you about supportive care in myeloma. So supportive care is really important, and it focuses on the effects of myeloma, the disease itself, and as well as side effects of the therapy. And we're also going to talk about preventative or prophylactic care. So not everyone with myeloma will need all of the supportive care measures, but it's important to be aware of them and to know how important they are and they can be. So the overall aim when having myeloma treatment is to get the maximum response to the treatment, getting rid of the most amount of myeloma cells while balancing this out with good quality of life. So the response to treatment depends on a few different factors. So this can be your age and your fitness, prognosis and what stage you're at in your myeloma, intensity of the treatment, how long you're on treatment, and if you have any treatment breaks. And then there's a few factors that can affect your quality of life, and that can be how well we prevent adverse events and how well we're managing the side effects and treating any other conditions you might have as well as your myeloma. So when we talk about supportive care, we talk about two different areas, I guess. So symptomatic care, so that's treating symptoms of current problems, so damage caused by myeloma itself and damage caused by the myeloma treatments. And then we have preventative care or prophylactic care, and that's preventing known side effects and reducing any worsening of side effects. Yeah, so myeloma, the disease itself, can cause problems in the body, and some of them that we're going to talk about today are kidney impairment, anemia, bone disease, pain, repeat infections, and peripheral neuropathy. And then some of the symptoms caused by myeloma therapy, some of these double up, like peripheral neuropathy and infections, and we'll also talk about steroid side effects, which I know have been mentioned already today, but I know it's a hot topic, gastrointestinal upsets and blood clots. Okay, so firstly I'll talk to you about supporting the kidneys. So it's a really important topic in myeloma because myeloma can affect the kidneys in lots of different ways. So some people's myeloma cells can make proteins called light chains, and when these levels build up and get high, they can actually block the filtering network in the kidneys and cause damage. And other factors that can affect your kidneys can be age, dehydration, some medications, and also high calcium levels can worsen kidney damage. And this is caused by myeloma impacting the bones, which I'll touch on a little bit later. So when the kidneys aren't working as well as they usually would, there can be a build-up of waste products, and that's where in your blood test you can see higher levels of urea, creatinine, your calcium can go up, and sometimes you can get proteins in your urine like albumin and, for some people, Bence-Jones proteins. So supporting the kidneys is really important, and we really try to reduce that burden of those light chains, correcting any metabolic imbalances to try to restore kidney function. So treatment can involve supporting the kidneys by increasing oral intake, so drinking more and sometimes intravenous fluids. Sometimes we can use diuretics, so they're medications to remove excess fluid and the load on the kidneys and stop build-up of fluid. Avoiding non-steroidal anti-inflammatories like ibuprofen, bisphosphonates, which I'll also touch on a little bit later. They can lower the calcium levels and then improve kidney function. And sometimes dialysis is needed. And this can be like a short-term option and sometimes longer term for some people. And even though kidney impairment is pretty common in myeloma, only 10% of people go on to actually need dialysis. All right, so now I'll talk to you about anemia. So anemia is actually a low level of red blood cells, and it's unfortunately another common complication of myeloma. So our red blood cells are really important because they actually carry oxygen around our body. So with that being such an essential function, you can imagine you get some follow-on effects if the levels are low. So you can get dizziness, shortness of breath, fatigue, amongst lots of other symptoms. So it can be caused from a few different reasons. So if you think of the bone marrow like a blood cell production factory, and the stem cells are workers that build blood cells. So myeloma cells come along and crowd out this factory so the workers can't go in and build the blood cells. This is one of the reasons why myeloma can cause anemia. And then the myeloma treatments can also cause anemia or worsen it because they suppress those worker cells from making the red blood cells as well. And as I talked about, kidney failure is common in myeloma, and our kidneys are really important because they make a protein called erythropoietin, which stimulates red blood cell production. So it's the main growth regulator of red blood cells, and it boosts the worker cells to make the red blood cells. So when the kidney cells are impaired, they don't produce as much of this hormone, and the worker cells don't get that boost, and there's, again, less red blood cells. Okay, so now we'll talk about bone disease in myeloma. So as you can see, it's unfortunately a really common effect of myeloma. About 80% of people with myeloma experience bone disease at some point. So generally what happens is there's a happy medium between cells called osteoclasts that break down old bone and osteoblasts that replenish it. And myeloma comes along and really disrupts that happy medium. It boosts the osteoclasts, breaking down bone, and it suppresses the osteoblasts from replenishing it. So as you can imagine, you get breakdown of bone and it's not being replenished. So this is where lesions occur, weak bone areas, and any little bit of stress on those weak areas like a sneeze or a twist or a cough can potentially cause a break in the bones. So as you can imagine, that can have a pretty big impact on quality of life. So another issue with bone disease in myeloma is calcium is stored in our bones. So if our bones are breaking down, calcium is being released then from our bones into our blood and building up. And as I talked about just before, build-up of calcium can cause or worsen kidney failure. So managing bone disease, you might have heard of, so bisphosphonates, you might have heard of Zometa or Pamidronate. So they're a class of drug that are used to help manage bone disease and slow further damage. So they can prevent fractures, which is really, again, important for quality of life. And as they prevent the bone breakdown, they also keep the calcium in the bones. So it prevents high levels of calcium in the blood and then in turn helps our kidneys. Another treatment can be radiotherapy. So radiation focuses high energy X-rays that penetrate body tissues to reach and destroy cancer cells. So radiotherapy can be used to treat bone pain as well as prevent fractures. Surgery is another option, especially when bones are needed to be stabilised if they're fractured. And a serious complication of myeloma can be a fractured vertebrae and causing compression on the spinal cord. And sometimes surgery is used to treat this as well. Now, an issue that can arise, it is a rare condition, but it can arise through use of bisphosphonates, is osteonecrosis of the jaw. So basically what this is, the mucosal cells, the cells that line our mouth, they break down and our jawbone is exposed to the outside of the mouth, and then that can cause infection and necrosis. So preventing that is really important. Doing a full dental check before starting bisphosphonate therapy, getting extractions done hopefully before therapy, but if you need them done during therapy, talk to your doctor about having a break from bisphosphonates, and really keeping on top of your oral hygiene and getting regular dental checks. All right, so now I'm going to hand you over to my colleague, Natasha Clark. Thank you so much.
Thanks, Rachel. Myeloma is a disease that causes suppressed immunity, and it does this in a few different ways, and Dr. Siddiqui touched on them when he was giving his talk initially. One of the things that myeloma does is it in an effort to escape our own immune system from killing it, is it has the ability to suppress the cells that detect and kill anything foreign within our body. And in its way of trying to avoid our own immune system, it also causes the immune system to be not very effective in killing other germs and foreign bodies that come into our body. And so some people were actually diagnosed because they've had recurrent infections because of that. The other thing it does is it suppresses the body's ability to produce antibodies, or our fancy term for it is immunoglobulins. So if you remember, Dr. Siddiqui was explaining that myeloma is a disease of plasma cells, and plasma cells in the normal body produce antibodies or immunoglobulins. So if the myeloma is taking over and isn't producing normal immunoglobulins, it's instead producing paraprotein, you won't have the right number of immunoglobulins to fight infection. Thirdly, as Rachel pointed out, myeloma can crowd the bone marrow and push out the normal cells from the bone marrow. And so in the same way that it reduces the production of red cells, it will reduce the production of white blood cells so that your body doesn't have enough white blood cells to fight infection. And so it doesn't really matter at what stage you are in your myeloma, whether you've got smoldering myeloma, whether you've got active myeloma and you're on treatment, or whether you're off treatment, everybody with myeloma will have a suppressed immune system and are more susceptible to infection than the general public. And it's just something to be aware of. Obviously, that severity rises and drops depending on where you are with your treatment. Somebody who's immediately post-transplant is going to be a lot more susceptible to infection than a smouldering myeloma, but everybody is. And then when we give treatment for myeloma, obviously we reduce your white blood cell count then as well. And so you become more susceptible to infection. And so what this means is that prevention, sorry, I'm just trying to get my slides to work. Prevention is key. And so, you know, I'm not going to go into too much detail because of your treating hospitals would have rammed it home about how important it is to attend hospital if you get a high temperature, that you need to educate your friends and family on protecting you from catching infection. But there are a few other things that we do, and Dr. Siddiqui also discussed going on antimicrobials for infection with certain treatments. Also, if your white blood cells aren't recovering well enough, your doctor might put you on injections to try and help you recover. And the other thing that's really key, and it's very topical at the moment, is having vaccinations. And vaccinations, as we know, help protect us from some of the common diseases that are out there. So it's really important that you get your annual flu vaccine, your annual pneumonia vaccine, COVID vaccine, and if you've had a transplant, all your childhood vaccines again. There has been a bit of discussion in the media that people with blood cancers don't necessarily get a very good response to the vaccine. However, some response is better than no response at all. So they are really vital, and we do impress that you need those vaccines. If your immunoglobulins become too low, you may be just trying to get, oh, there we go. You just may be more susceptible to recurrent infections. And so your hematologist may suggest that you need to have some immunoglobulin replacement. Traditionally, this has been done intravenously, and some of you are probably already on it. You come into the hospital once a month, have about a 3 to 4 hour infusion of the immunoglobulins. And that does a really good job of helping to prevent regular infections. Over the last few years, they've actually developed a subcutaneous product, which means that the immunoglobulin is injected subcutaneously, which means under the skin. It's a product that's given weekly, and it's given over 20 minutes, but the bonus of it is that it is something that you can manage yourself at home. And some hospitals and some centres are already doing this. It's a program which takes a lot of resources to start up within a hospital, and so not all places are doing it yet, but I do think it is something that we will look to in the future and will become more common, purely because it is a process that is a lot more user-friendly for the patients, and it reduces your burden. Okay, so peripheral neuropathy is a really common either side effect of the myeloma itself or a side effect of the diseases. It is something that occurs when there's damage to the nerves, either in your fingers and your toes, somewhere in the periphery of your body, and there is an interruption of the message from your peripheries to your brain. So it can either just give a bad message or no message at all, in which case you become quite numb. And so the ways to treat peripheral neuropathy, if we can catch it early enough, that's key. And so it's really important that you tell your doctor and your health professionals if you're getting neuropathy and if it's affecting your function. A classic test is, can you do up buttons? And a dose reduction will generally help reduce that. Other things that we use, there's some non-pharmaceutical treatments like rubbing in Denko rub into the area, cocoa butter massage, etc., which is really good, which are all outlined in the peripheral neuropathy book. I could talk along this way for over an hour, so I haven't got time for that today. But I strongly suggest that you read our book. It's very comprehensive. There are also pain-relieving drugs for peripheral neuropathy, which are very different to your classic Panadol, ibuprofen, or even the opiates don't really help. So they're very specific drugs that your hematologist will know about. So the next side effect I'd like to talk about, if I can get my clicker working, is steroids. And as Dr. Siddiqui said, there are many, many side effects with steroids, but I think something I'd like to focus on, sorry about the clicker there, is the psychological effects that can be quite intense. And so they can range from sleeplessness and following on from the sleeplessness, fatigue, to quite intense agitation, anger, depression, and in very rare instances, psychosis. So if you find that, that it is very distressing, the side effects from steroids, again, have a conversation with your hematologist, and it might even mean that you need to ring them before your next appointment to make sure that gets addressed soon. There are many other side effects associated with steroids. Gastro upsets, it can cause reflux, so it's really important that you take your tablets with food, and you're probably on an anti-reflux medication for that. You have an increased risk of infection again. You might experience bloating, muscle cramps, all sorts of things. Whenever patients are talking to me about their side effects, I go, yeah, that's the DEX. And everybody knows. But the important thing about the DEX, to know about the DEX, is it is a vital part of your treatment. However, we can always do a dose reduction of the dexamethasone, as Dr. Siddiqui said. Gastrointestinal upsets are generally around diarrhea and constipation. Nausea isn't such a problem, although some people are susceptible to Velcade, which is why you usually get an anti-nausea drug before you have it. Diarrhea and constipation can be managed quite well. So again, really important to have a conversation with your health professionals about it. If you're getting diarrhea, please avoid fatty foods, acidic foods. And with both diarrhea and constipation, it's very important that you are drinking lots. So my next discussion is blood clots, which Dr. Siddiqui covered quite nicely for me as well. But just to give you an idea of what you're looking for, if it's a deep vein thrombosis, it's going to be in a limb. It'll just be, importantly, usually just in one limb, and you get a red hot swelling. And this is something that needs to be addressed really quickly. So you need to get to an emergency department and have it checked out, because we don't want a bit of it breaking off and flying into your heart or your lungs. If it does go into your lungs, you can get what we call a pulmonary embolism. And then you'll experience shortness of breath, chest pain on deep breathing, and it can be life-threatening. So it's really important that you get to hospital straight away, call an ambulance. I'm not going to go through. So we've briefly covered side effects and supportive care in myeloma. Each one of those topics we could talk about, in a seminar on its own. What's really important is that you keep up your dialogue with your health professionals, talk about things, maybe keep a diary of your side effects. We have a diary, a treatment diary, where you can actually list all your side effects and show your doctors what you're experiencing. And in that way, they can tailor your treatment to you. You can always call the 1-800 myeloma line and talk to a support nurse about your experiences and get some tips and advice that way as well. So thank you very much for listening today, and I hope you enjoy the rest of the seminars. Thank you. Bye-bye.
Thank you so much, Rachel and Tash, for your very informative presentation and for your time this morning. We do have a couple of questions. The first question is, I'm not sure if I should have the COVID vaccine. What should I do?
Okay, I'll address that one. Our myeloma scientific and advisory group, and generally hematologists the world over, strongly recommend that myeloma patients get the COVID vaccine. Next week, we have an infectious diseases specialist coming to talk about infection control in myeloma, and he'll talk a lot about COVID vaccines and about the COVID disease itself. However, we know that that providing some sort of cover is vital to keep you safe from COVID, and also your families. it's fairly vital that they get that vaccination as well so that they aren't at risk of giving it to you.
Great. Our second question is, how long do I need to be on Zometa for?
So that will really depend on your hematologist and the doctor. Yeah, they usually determine, I guess, how long you're going to be on Zometa for.
And I get flu-like symptoms after Zometa. Is this common, and should I tell my doctor?
Yeah, it is a common, unfortunately, it can be a common issue with having Zometa, and definitely let the doctor know and talk to the doctor about issues you're having when you're having the Zometa infusion, and they can advise you to have any medications that might help. Even just taking Panadol and things like that can help with those symptoms.
Great, thank you so much, Tash and Rach. I'd just like to remind everyone, as Tash said, that if you do have any questions or concerns about the flu vaccine or the COVID vaccine, to please join us for that seminar on the 15th of May, where we'll have an infectious disease doctor presenting, and you can ask any questions to them. I'll pass you over now to EJ for our closing statements.
Thank you, Emma, and thank you, Tash and Rachel. Thank you once again to all of our speakers for your fantastic presentations. To Brian, Steve, Haseeb, Christine, Daniel, Tash and Rachel, we here at Myeloma Australia hope that you, the myeloma community, have enjoyed this very first seminar. Please remember to complete the evaluation forms underneath this live stream. If you'd like to purchase one of our great 38 mate caps, please head up to the shop button to purchase your cap. For more information about our 38 Mate Awareness campaign, you can head to our website. Here you'll be able to learn about the campaign, view the stories of our 38 mates, and peruse the photos. Thank you to all the staff at Myeloma Australia who've helped in putting this seminar together today. Additionally, the production team at CVP who've brought you this broadcast today, you guys are fantastic. As Steve talked about previously, we have two more online seminars on the 15th and 29th of May. There will be a local face-to-face events during the month of May in Melbourne, Hobart, Sydney, Adelaide, Perth, Brisbane and Newcastle. If you've not received an invitation, please head to our website for details on exact date, times and locations for these functions. If you're new to Myeloma Australia and have not signed up to our database, please head to our website www.myeloma.org.au. Here you'll be able to receive information and invitations about our future seminars and information and support groups in your area. Myeloma Australia has a telephone support line for patients, carers and anyone affected by myeloma. It is manned by wonderful specialist myeloma nurses Monday to Friday, 9 to 5 Australian Eastern Standard Time. Additionally, our resources that are available as well. If you'd like any resources, please email or call our head office. These resources can be found on our website and downloaded. Our support nurses run support groups throughout Australia, and if you're interested in joining one, please again call head office and complete the form on our website. Thank you again, everybody, for tuning in and joining us on our very first myeloma seminar. We look forward to seeing you again very soon. Have a great day.